just put some cold water on the kidney, we go very fast. If you do under 30 minutes, even its cooling is not necessary. But we have washed it with cold saline, and within 20 minutes, venous and arterial anastomosis, about 20 minutes is finished. These are bulldog clamps. Oh, excuse me. Sorry. Oh. This is we put one bulldog clamp here, and we remove the others, so let the vein fills up. So we have a wide anastomosis, then we suture. And then we go to the artery. This artery is anastomosis exactly similar to the vein, to the common iliac artery. This is artery finished. Again, we remove the clamps. You can see now pulsating artery and vein. And this is the bladder. We anastomose by modified Licht technique, the ureter to the bladder. And then we finished anastomosis, pull the muscle of the bladder over the ureter. Thank you very much. Sorry to taking your time. I hope we could have good collaboration with our brother country. Thank you very much.
Thank you very much, Professor Froush. We'll have 5 minutes for questions, maybe more. Questions? Mohammed, please.
Thank you, Professor It was very educated and clear. Just one question about the ureter anastomosis. Is it also one suture like the...
No, for ureter, since the time was not enough, I wanted to go fast. I could show that. We do modify Licht. It means we make about 2 centimeter incision in the detrusor muscle of the bladder. And we see the mucosa without dissecting too much. And we open about 1 centimeter. And we put 2 vicryl suture. And then we do it continuously, one side, and then we go tie and we go around the other side. So we do with 1 vicryl suture, but the 2 parts are sutured and then go around it. So we use 2 suture for ureter, usually.
Do you use any stents?
Yes, that's a good question. We always thought what to do, because that's a problem. If we put a stent, we have to do cystoscopy to remove it, and sometimes doing cystoscopy under local anesthesia, it is very cumbersome for the patient, and we always thought to put or not to put. Finally, recently, in the last year, we have come to a conclusion. We put a stent, but we tie it to the ureteral catheter. And then we remove the ureteral catheter after 15 days, about 15 days to 3 weeks. When we remove the catheter, double J also comes out. So we really feel that we have to put double J because, especially in ladies, the bladder is thin, and if you remove it soon, clots might cause a problem in the anastomosis, or any problem happens that we are happy that the stent is there and that factor is away. If the urine comes down or anything happens, we're not worried. So we did a study, everybody has done a study, even not significant, but always the stent group has better, less fistula and stricture. So we did have also the study. So now we put stent, but we remove it with Foley catheter without cystoscopy.
Joseph?
Yes, sir. Thank you very much. Almost, yes. Yes. That's a difficult question. As Professor Nabil knows, there have been very big discussion. From the beginning of transplantation, I personally wrote the sentence and took it to Ministry of Health and Medical Council, Iranian Medical Council, that in Iran only each citizen can donate to his own or her citizen. It means Iranian only to Iranian. We had 2 million Afghani refugees, not one Afghani donated kidney to an Iranian. So Afghani to Afghani, whoever comes from each country with his donor. And now it is seriously considered that probably the transplantation from foreign country, it might be stopped completely. It is now Iranian Transplant Society has recommended this, and it's going to be decided soon in Ministry of Health that we might stop the transplantation, especially for those countries they already have transplantation in their own country. So this is one issue that stopped some of those rampant commercialism that you think about it. But we always thought that desperate recipient, because there is 107,000 patient recipient waiting in waiting list in the United States. And about 30,000 patients, recipients has died since 99 in US waiting for a kidney and not receiving kidney before their death. So if the mortality both under dialysis and even after transplantation will go high if you have patient waiting for long for a kidney. So we thought in this way, we have accepted to do living unrelated even if you don't like it. But hospitals and doctors and nurses are not involved in this act of donation at all. Only usually we try to have a charity foundation run by dialysis patient, get the donor and recipient together. And in this way we feel we have been able to save many lives of recipients for the sake of our patient. And as you know, in the States now, they are thinking, they have brought now paired donation, wives, and also in the name of friends, they are doing living unrelated. And in fact, the highest rate of growth in, it has doubled in US living unrelated transplantation in recent years because the cadaver transplantation is in plateau. And all over the world, it's about 45% of transplantation is in living in US and some European countries, and all over the world is about 42% from living and the rest from cadaver. So our aim is cadaver, and we are trying very hard for cadaver, and we hope still decrease more in living, but we feel there will be a balance between living and cadaver transplantation for many years to come. So we have accepted only for the sake of our recipients that they are in poor conditions. Especially you can see these 500 children would die because they cannot go under hemodialysis or they go under peritonitis if you do peritoneal dialysis, and it is very difficult for children. They don't grow, they have a lot of problem, and the kidney transplantation is the only hope for children.
Okay, Adil? Adil is our hepatobiliary surgeon.
Beg your pardon?
Hepatobiliary surgeon.
Oh, thank you very much.
regarding the ureteric bladder anastomosis, what do you think of dividing the distal ureter in a spatula shape?
Yes.
And,
Well, we try to have the ureter as short as possible
and
because we don't like distal tip.
When it is spatula shape, then the anastomosis is wide, and you don't need to put any stents.
You are right. We have done this study. I said we always have thought to put or not to put. Since we do many transplantation in diabetic patient, obese patient, difficult cases, so we find out to put the stent is safer, but you can
And the other
go
point,
away without it.
And the other point, the approach in donor nephrectomy. Do you think the retroperitoneal approach is better than transabdominal? I thought it's transabdominal approach here.
Yes. If you look in the history of laparoscopy for all the procedures, we have done about 5,000 laparoscopic procedures in our department. We just published in SLS journal, Society of Laparoscopic Surgeons, 5,000 cases. We do open access instead of using trocar, needle and blind trocar. So they have shown that if you go transperitoneally, you have better anatomic view, you have wider space to play, and if you have obese patient, anatomic variation, you can handle them better. So you can see most of the centers, they are doing transperitoneal, and they have not shown much different results. For example, I have done a lot of stone surgery with laparoscopy. There have been cases that I did repeat laparoscopy, and I found almost not much adhesion. So I think it's not important, it's your choice and to your experience. If you are experienced with retroperitoneal, that's better. If you are familiar with the transperitoneal, but since we have fellowship and we have training program, it is much easier to teach transperitoneally because you can see beautiful anatomy, better space to work with.
Khalifa? Short and quick.
So, Prof, thank you very much, Khalifa Al-Wahibi, vascular surgeon.
My pleasure.
Congratulations for the vast experience and vast excellent outcome.
Thank you very much.
And again, to know that the unrelated living and cadaveric, they are as good as living related in outcome and graft survival. And again, whatever reason is there for immunosuppression, for HLA typing, for the tissue typing, but I believe is your excellent system of recruitment, transfer time, and again, transplant service you have and transplant surgery itself. So congratulations for that. My question for the cadaveric, and again, we are running short of resources all over the world. Is there any experience or was there any thought on non-beating heart cadaveric transplant?
That's a good question. We have not started that, and as you know, that needs a very mobilized and very good experience and team and a very good coordinator because you have to have the cannula there, you have to talk to the patients while patient is not died, and so on. I think that's a very good idea, and many centers have started non-heart beating programs, and we hope we can also start, but so far we have not started that. And for cadaver transplantation, we are in the beginning of the road yet, because in many smaller cities, transplantation is done mostly from living, and only in Tehran and Shiraz and few cities, cadaver is now active. And we hope when we gain more experience, especially training good coordinators in future, this is another step to increase the cadaver donation. But still, in the West, only, I think, 3% or something like that are from heart beating. It's going to be a source, but not a big source. And especially, these kind of kidneys are usually not good quality kidney because they are, I was in Spain, and they used from older donors from CVA, this kind of kidneys, and these usually, they don't work, they are not good kidneys.
Okay, just a question. You said you compared the laparoscopic donor and the open donor nephrectomy,
Yes.
and there were similar results.
Yes.
Did you find any advantage of doing laparoscopic statistically?
Yes, of course. See, as I mentioned, we did the first randomized study. It's published in PJU International, and it is referenced 140 times now. Because when I presented the first 50 case of RCT, Dr. Qaaboos said, I said, this is going to be 100. I said, bring 100, bring 100. And this became the best laparoscopic paper in the Euro Society in 2004, because everybody was waiting to give the same question you're asking. And the graft outcome was exactly similar, but the morbidity is definitely less. So in a young brother or sister, you have to divide 3 layers of muscles. And if you see in the slides, after 3 months, you don't see any incision, because many young donors, they don't want to be known that they have been operated. If they go to swimming everywhere, you only have 2 holes, cosmetic. 5 millimeter or 3 millimeter. They have, of course, hospitalization is not different. They say usually different. But both open and laparoscopy, they were discharged from our department in 2 days. But postoperative pain, analgesia, and incision pain, all of these, and hernia and everything was much less in laparoscopic group. Of course, the teaching period is more difficult for laparoscopy. Everybody is familiar with open surgery, but laparoscopy, the only point is you really need good time, because donor is very important. Not even one mortality or morbidity is accepted. And I did review the whole literature in the world. Mortality of access. Access mortality is usually not reported. They put needle and trocar on the blind, and they hit the aorta, and they cannot handle it. Those people are not vascular surgeons, and they have many mortalities. And in the first 300 cases of any kind of laparoscopy, we had 3 major vascular injury that, since I knew vascular surgery, I could handle them. Front and aorta was hit, but I handled it. But after 300 cases, we elected the open access technique, the 1 centimeter incision in the umbilicus trocar size, we call modified open access. We don't put needle, and we don't put any blade, we just put the plastic trocar. And since then, we had not even 1 vascular injury, aortic or things. So we published this, that the safest way is to go open access, and laparoscopy is definitely superior. I don't remember when I did the open pyeloplasty. I've done over 300-400 adrenalectomy, over 400 pyeloplasty. Even we just published children under 1 year age in Pediatric Urology Journal about 40 cases of laparoscopic pyeloplasty in newborns. So I think laparoscopy is good. If you have time, if you have experience, you should be dedicated. You have to, because it needs more time to learn, so you should not look for good money, because at the time you are in the beginning, when you start laparoscopy, you can do 2-3 open surgery. But when you gain experience, now our donor nephrectomy is finished in 1.5 hours. Our pyeloplasty is finished 1.5 hours now. It was about 3-4 hours when we used to start.
Sure. Thank you very much, Dr. Sam.
Thank you very much. Sorry to take your time.
Thank you. We go to the Omani part now. And may I introduce Dr. Nabil Salmeen. He is an associate professor at the College of Medicine, and he's a very famous nephrologist in Oman. And he has taught many of the doctors sitting in this room, including myself. And he's going to talk about the renal transplant experience in Oman.
Thank you very much, Dr. Hani, for the nice introduction. I'm very honored to see my dear friend and colleague, Professor Forosh. In fact, there is one thing that he did not mention, is that he was the initiator of the fellowship program in the Middle East Society of Organ Transplantation. He initiated it, he gave the idea, he formulated it, and now nobody mentions his name, but he was the initiator of the fellowship program at the Middle East Society. So we worked together with Dr. Hani, that I'm going to present some of our data. In fact, the purpose of our presentation is not only to show our program, but also the main idea is also to see the areas of improvement and the areas within which we may benefit from our colleagues' experience. So we will have an overview. We will talk about transplantation in Oman, the history and our future perspectives. We are optimistic. History of transplantation in Oman. Till 1970, Oman had only one missionary hospital. In 1983, the first nephrology service was established with hemodialysis, and an agreement was signed between Oman, the Ministry of Health of Oman, and Oxford to perform living-related transplantations at Oxford. So the donor, recipient, and one attendant were traveling there. And from 83 to 88, about 88 transplants were performed within this program. In 1988, Oman Transplantation Program was established. It was a joint venture between Sultan Qابوس University and the Ministry of Health. It was when Professor Dar came, and it was also with the collaboration with Dr. Qasim and Dr. Mohammed Al-Hassani at that time, and Dr. Hamoud Marhoubi. And soon after the establishment of the program, the first living-related was performed, and 2 deceased donors were performed in Oman. In 1992, the first pediatric transplantation was performed. In 1994, the first pediatric deceased donor transplantation was performed. In 2009, we performed 3 paired donor exchange. That means the donor recipients were not matching, but then we could exchange the donation with the other couple. And I should say that I don't know in 1998 because I was not here, but in all these transplantations, Dr. Qasim was assisting Professor Dar. In 1993, the legislation for organ transplantation was approved. Living-related transplants were permitted. Brain death was recognized as legal death. Disease donor transplants were approved. And the next of kin consent is with a compulsory next of kin approval. This is to take into consideration the religious and the social context of Oman. Emotion-related transplantations were accepted, provided we have a ministerial derogation, and there's interdiction of any sort of commercial transaction. In fact, when we visited His Eminence, the Mufti, it was Professor Dar, Dr. Mohammed Hassani, who is now back in the UK, Dr. Qasim, and myself. So what is the current situation? Now, we will have an overview, and then we'll go on to see in depth about our figures from 1883 till 2013. 1,656 transplants were performed on Omani individuals. Transplantation, that gives a transplantation per million per year of an average of 40.2, which is excellent. In fact, if we compared with Europe between 2004 and 2013, it was 37, and US in 2013 it is 44. So if we take this figure, we are one of the best in the world. Usually in transplantation, there is a preponderance of male recipients. And in our program, the male to female ratio was 1.34, which is very reasonable. And at the moment, till end of 2013, we have about 690 patients with functional transplant, and that gives a crude graft survival of 42% over 31 years, with a range between 1 to 372 months. So, some of our achievements in our program. We hold the world record for the youngest disease donor. It was in 1994, and it was performed here at the university by Professor Dar, assisted by Dr. Qasim. And the donor was a premature neonate, 33 weeks of gestation at the age of 10 days. It was a Dutch couple, and in fact, they offered this kidney to the Netherlands. They refused it, and then Professor Dar accepted it, and he called me. We had discussion, and we went along. And the recipient was a 17-month-old child. He was almost dying because he was on PD with multiple complications. And this boy is still alive. He's now 21 years old with the same kidneys. We have reported this. This is reported in Transplant Worldwide Records by Terezaki, and we presented it in the Second International Congress of Pediatrics in Paris in '96. We performed the first genetic analysis in renal diseases in Oman in 1995. Again, it was Professor Dar who contacted the Karolinska Institute in Sweden, and we could send the blood of a child with Dinestra syndrome. These people are prone for Wilms tumors, and they have the WT1 mutation. So we sent the blood, and it came positive. And for this child, we performed, Professor Dar, and I think also assisted by Dr. Qasim or Dr. Kahinde, bilateral prophylactic nephrectomy, and he's doing very well now. And we reported this in the symposium at the university here in the year 2000. We reported the first case with Campistol. Professor Frosh knows him. The first case of regression of Kaposi sarcoma in a transplant patient, and that was the third series of cutaneous Kaposi sarcoma, and the regression took place 9 months after the conversion from cyclosporin to sirolimus, which is mTOR inhibitors, and now it is the standard of care that whenever there is Kaposi sarcoma, the first approach is to convert the CNI, cyclosporin, or tacrolimus to sirolimus. We also reported the first regression of cutaneous B-cell lymphoma in transplant patients after conversion from cyclosporin to mTOR inhibitor. And this is the transplant, and this is the stain of the lymphoma of the B cells in the biopsy. Usually, even for example in the States, it's about 60-70%. Even in Switzerland, it's about 2/3 to 1/3. Usually, when the transplants between the couples, it's usually the wife is the donor and the husband is the recipient. So we looked into our figures, and in fact, although the number of couples was not big, it was 24 couples, but there was no this gender, what we call the gender imbalance between spouses, and we didn't have this gender imbalance. It was balanced, but of course the number is small, and the difference was not statistically significant. But I should say this is not an achievement of our program. It is a social achievement. That shows that we are not very sexist, and Omani population is very open. And in fact, even when I say that in 1983 to 1988, 88 transplants were done, living-related at that time, that means that the population is open for transplantation. So I think there is some deficit from our part in terms of public education and awareness. So what are the areas of improvement? Now, there is a pressing need to increase our transplants. Now, I gave the figure of 1,656. It comes to 14.2 per million population per year. That's correct. But most of these transplants